All right. Good morning, everybody. Happy Friday. Thank you for joining our session today. Before I go ahead and introduce our speaker, I just wanted to go over some quick general rules for the session. So everyone should be muted right now. If you could stay muted, that would be great. All of our workshops will be recorded and posted to our website at a later date. So if you want to go ahead and disable your video, that'll ensure that you won't appear in our recording. To ensure that you have a good view of our speaker today, go ahead and put enable active speaker mode. You can find that in the top right-hand corner of your screen. And then if you have any questions during the session, please feel free to use our chat box, enter those. We will have some time at the end of the presentation to read those off. So our speaker for today's workshop is Amy Abrams. Amy has worked in the field of long-term care in San Diego for 20 years in care management, dementia care, and community health education. She holds a joint Master of Social Work and Master of Public Health degree from San Diego State University and is a certified positive approach to care dementia trainer. A passionate educator and vocal advocate for older adults with disabilities, Amy currently serves as the Director of Education for Alzheimer's San Diego, a local nonprofit organization whose mission is helping families today while finding a cure tomorrow. Please join me in welcoming Amy today.
Thank you so much. Carolyn, I just want to confirm my audio is working. Everything sounds good. Okay, great. Wonderful. Well, my grateful thanks to the County of San Diego for inviting me to talk about this very important topic. Why it is exactly that dementia increases fall risk is a topic of a lot of confusion to a lot of folks. You know, why is it that having a bad memory would put somebody at risk of falling more often or make the consequences more significant? But there are some reasons for that. We'll be talking about it, and most importantly, what we can do about it. So let me make sure I'll get my controls working here. Here we go. So you heard about me. That's my background. I work for Alzheimer's San Diego. We are a local nonprofit organization headquartered in Kearny Mesa, but currently we're all, of course, working remotely, like probably most of the world still. And very pleased to be here with you today. So here's what I intend to cover during our hour this morning. I'm going to talk about briefly the physical and cognitive symptoms of dementia, what exactly is changing in the brain and how that impacts a person's risk of falling. We'll talk about things we can do to reduce the likelihood of falls. We can't do this perfectly, but we can lower risk in people who are living with dementia in the home, in residential care settings, and of course out in the community as well. And then I'll make sure that you know about additional resources for assistance. And I am intending to leave some time to take questions if you have them. So please type those into the chat and send them if you have them. So let's start with the symptoms of dementia and how they impact a person's fall risk, right? So first, if you've been participating in any of the other terrific programs all week, you've probably heard a lot about the general risk factors for falls, right? We are at more risk as we age, people with balance and mobility issues, people with sensory impairment, not just vision impairment, but hearing impairment. Also increases a person's risk of falling. Frailty, becoming less flexible, having less muscle strength, stiffness, dehydration, malnutrition, taking medications, things around the house, right, that present obstacles and trip hazards for us. The fear of falling actually begets more falls, unfortunately, as you may be familiar. And then individuals with dementia are actually in an entirely different high risk category. Why exactly is that? First, just want to clarify the term dementia in case anybody isn't clear what I'm talking about. Dementia is not one specific disease. It's not one particular condition. It's the word that we use to describe a syndrome, a set of symptoms that are caused by some underlying medical condition. So that condition is frequently Alzheimer's disease, but it's most often Alzheimer's disease, but certainly not always. There are dozens of different medical conditions, some of which are temporary and treatable and reversible, most of which, however, are chronic and progressive, like Alzheimer's disease, Lewy body dementia, frontotemporal dementias, vascular cognitive, vascular conditions that cause cognitive impairment. These are progressive. Unfortunately, they don't get better. They progress over time. We don't have an effective form of treatment for these progressive forms of dementia. So when a person is living with dementia, we will see a cluster of symptoms. It's much more than just a memory problem. Memory is often impacted and significantly, but not always. But that is just one sort of primary, very common symptom of these conditions that we lump together and call dementia. So when a person is living with dementia, there is organic disease in the brain. Brain cells are being affected, and eventually, depending on the type of dementia, brain cells are dying, right? Most forms of dementia do start in the temporal lobes of the brain, in the middle of our brain, our medial temporal lobes, specifically in a region called the hippocampus, which is heavily involved in our short-term memory. So that's why people with Alzheimer's disease, people with many other types of dementia as well, do exhibit significant short-term memory impairment, even very early on in the disease process, while other symptoms may be very mild or even totally non-existent, and long-term memories may be intact. You know, I still am oriented, I still know who I am, I know where I live, I know how to navigate through my neighborhood, but I cannot tell you what I ate for breakfast today. Right, the short-term memory. That's a very common symptom in dementia, and that's just, or in the Alzheimer's type of dementia. And that's just a product of where in the brain the disease has, the pathology of the disease has kind of taken hold. So I really like for people living with dementia and care partners to understand a little bit about the different lobes of the brain and what they do, because it really helps us to have some understanding of what's going on right now in this moment, what we might expect to see down the road. And it also allows us to have sort of a different level of empathy and forgiveness and understanding of ourselves when we're forgetting things or doing things. And certainly as care partners, it allows us to be more empathetic toward other people, to remember these things that are happening, these things that they're saying and doing, while they frequently feel intentional, they're not, right? They are symptoms of a progressive condition. So most forms of dementia, as I mentioned, will start in the temporal lobes of the brain. And then the Alzheimer's type of dementia, the sort of next region of the brain where it is likely to spread is up into the frontal lobes of the brain, which is a huge region up here, kind of back behind our foreheads. When there is damage in the temporal and frontal lobes of the brain, we're going to see symptoms like those that you see here on the screen. This is the part of the disease where memory begins to be impacted. We'll see that short-term forgetting, short-term memory loss, even when long-term memories are intact. Rapid forgetting is what we call that. So I may, for example, put a pot on the stove with some rice and water in it and walk away. And within moments, I can totally forget that I've done that. Disorientation, right? Becoming confused to where I am in space, right? Am I in my own home right now, or am I in someone else's home? I'm out at the shopping mall and then I'm trying to find my car, right? Becoming totally disoriented to where we are in space or place. But there's other forms of disorientation that are very common in dementia too. One can become, and frequently will become, disoriented to time. So not being, if I put that pot of rice on the stove, right, I might walk away and within, 2, 3, 4 minutes, it might feel to me like it's been hours since I put that on, and get up in a rush and run over to check on it, right? Disorientation to time will often impact a person's ability to function independently and to kind of navigate through their normal daily routines the way that they used to. Difficulty with sequencing is very common, especially when there's damage up here in the frontal lobe. That's the part of our brain that regulates our executive function. We sometimes refer to that as the CEO of our brain. It's the part of the brain that takes in lots of information, organizes it, and sequences it for us and tells us what we need to do in what order. And if you think about walking, navigating stairs, going up and down a curb, all of the things that we do to ambulate, either with or without the use of a walker or a cane, for example, it does require a very detailed set of sequencing that our brain needs to do, right? Exactly when to lift that foot in relation to the other foot, when to put the foot of the cane ahead of oneself, right? Or to make the next move with the walker, for example. That type of sequencing is actually, while it feels very natural and we're not really aware of ourselves thinking about those things in most cases, there's a lot of cognitive work that's going on to make that happen in your body. And that sequencing becomes impaired in people when there is damage up there, especially in the frontal lobes of the brain. There are, of course, more than memory symptoms related to dementia. Behavioral changes are very common in people living with Alzheimer's and other types of dementia as well. And behavior changes actually impact fall risk too, right? So a person who is becoming withdrawn or apathetic, someone who's being offered food, beverages, medication, right? Whatever it might be, and saying, yeah, no thanks, I'll do that later. Right? That type of apathy can actually lead to chronic dehydration, malnutrition, not getting the medications that you need, changes in one's blood pressure, right? Certainly. So it's sort of interesting to think about, but changes in a person's personality can actually increase the likelihood that they're going to have some of those other risk factors for falling that I mentioned before. Difficulty with initiation and termination. This is a very interesting symptom of dementia that not a lot of us are aware of. I'm going to reference a couple of times here this morning an occupational therapist who trained me and many of the staff at Alzheimer's San Diego, named Teepa Snow, who you may be familiar with, and I believe I've got her website for you in a slide or two here. Teepa Snow developed a method called the positive approach to care that teaches us a lot about, she's an occupational therapist and that's her background. She teaches us a lot about these brain changes and how they manifest, what they look like, and what causes some of these behaviors that we see in people living with dementia. And one of the really insightful pieces of information that she shares in teaching the positive approach to care is that often people have a really hard time just getting a task started, or once they have gotten that task going, right, making a movement, starting to clean out a drawer, right, walking, whatever the activity might be, it can be hard for the person to stop. So initiation and termination. So if you think about a person living with dementia that you know or have known, you can probably trace, you can probably think back to some of this behavior that you've seen. So this will result in wandering. Somebody goes to check the mail at the mailbox at the end of the driveway and just isn't able to sort of halt, isn't able to stop and say, I've reached my destination, right? That difficulty with termination. So they end up continuing to walk and going out and increasing risk of fall risk, increasing a risk of falls that way, right? Also, that difficulty with just getting started with a task can make it very difficult for somebody to get up off of, out of a chair, get up off of the couch in a safe manner. Finally, maybe the most important of this set of symptoms is that people frequently experience just generally a decreased safety awareness. This can mean my own personal safety, right? Knowing I need to take this medication to regulate my blood pressure, and having normal, stable blood pressure is important to reducing my risk of falls, right? This is an association, a link, a connection, a type of safety awareness that a person without dementia may have. A person with dementia may not be able to sort of sequence those thoughts, right? And have that type of safety awareness. But there's also just the basics of, I might not be able to tell that a set of steps is coming because of difficulty with my visual spatial abilities, which we'll talk about, and think to myself, you know what, that looks tricky, that looks a little dicey. I think I'm gonna ask for some help here, or I think I probably should bring the cane with me, or there's a handrail there, I should grab that handrail, right? Again, I just ask you to think about just how complex all of these cognitive tasks are and what they require of a person, to recognize why it is that a person with dementia might fall so much more frequently. So in the Alzheimer's type of dementia, we'll see it start in that temporal lobe in the middle of the brain, spread into the frontal lobes of the brain, and then spread further back, kind of up into the crown of the head. The parietal lobes are sort of up here. The occipital lobes and the cerebellum and the brain stem eventually are affected too. And when the disease moves into those regions of the brain, these are some of the symptoms that we might see. I want to be really clear that I'm describing a very typical progression of Alzheimer's disease, but it's just sort of a statistical average. No two people experience any of these conditions exactly the same way, so we can't exactly predict this spread that I'm describing. Just kind of making broad generalizations here about the typical progression that we see. But when there's damage in the parietal, occipital, and cerebellum regions of the brain, we're likely to see difficulty with language comprehension. So my saying to someone, oh, watch your step, right, might not be a helpful suggestion to them. What exactly does that mean? I don't see a step here, right? I might be thinking I'm looking for some kind of a step ladder, right? If I'm having a hard time comprehending vocabulary and language, your use of sort of helpful suggestions to me might not be well understood. Another thing that's important to know about people with dementia is that frequently the wiring in the prefrontal cortex of our brain makes it easier for people with dementia to understand what they see than what they hear. Now, of course, lots of caveats here. This is not necessarily true for somebody who's got vision impairment, right? Other types of sensory impairment will impact whether or not that is true. But keep this in mind, and we'll come back to this as we go along here. When we are trying to support somebody who's living with dementia, help to keep them safe, preventing falls around the house, when we're getting in and out of the car. Many of us, myself included, when I was trained to care for people with dementia 20 plus years ago, I was trained to talk. I was trained to tell people exactly what I'm doing, what I'm gonna do next, what I'm doing right now, and what we're gonna do right after this, right? To just sort of give people lots and lots of information. And what we're finding out is that that's actually not as helpful as we thought. That in fact, it can be much easier to show people what it is that we want them to do, to give them visual cues rather than just saying verbal words. Now, that isn't always an option. Sometimes you're not face to face with people, especially in this current environment. We might be separated physically from someone that we're trying to support. And of course, things like vision impairment, hearing impairment are going to change the realities of that too. But do keep that in mind, right? Vision changes and hearing changes don't happen at the same rate, right? And it might be easier for somebody to understand what you're saying if you can also provide them a visual cue to accompany what you're saying. Recognizing the function of an object. This is very important. I work with a lot of families who are caring for somebody who's living with dementia and at the same time beginning to develop muscle weakness and changes in gait and balance. And they're trying to teach the person who's living with dementia to start using a walker, to start using a cane. And we just have to keep in mind that learning to use tools, learning new habits is harder for people with dementia than people without dementia. And over time, as the disease spreads and as the symptoms progress, it actually becomes impossible for most people with mid and late stage dementia to be able to learn new things. If a person was not already using a cane, already using a walker for stability and improved mobility before they developed dementia, it's going to be much harder for them, if not impossible, for them to start using one after they develop these conditions. So keep that in mind when thinking about, sort of using assistive devices with someone that you're caring for. And then, of course, there are physical symptoms of dementia. These tend to sort of set in a little later in the disease because they're regulated primarily in these regions of the brain that are toward the back of the brain that we're talking about here. But this is not always the case. But we will see difficulty with fine motor skill, losing the ability to sort of control fingers, other types of dexterity. We'll see handwriting change, certainly, but even motor skills like gripping onto a cane or using the brakes on a walker can be difficult for someone with dementia, right? Just sort of the signaling between brain and fingers is not working properly. Sensory perception, I've referenced a couple of times here. I'll talk more about the visual field here specifically in a moment, but just keep in mind, dementia doesn't cause a person to lose their hearing or to lose their sense of smell explicitly, right? It's the structures in your nose, the structures in your ears, the nerve endings on your skin that allow you to feel, to smell, to hear things. But it's your brain that does the work of telling you what it is that you're seeing, hearing, smelling, tasting, touching, etc. And so sensory perception is impacted in folks living with dementia. So it can be harder for them. This is a big reason, especially when you combine it with this sort of change to the visual field, changes to a person's center of gravity. We frequently see people kind of shifting so that they're walking more on the balls of their feet. Sorry, you can't see how I'm standing right now, but I'm sort of posturing myself as though I were standing kind of facing forward. Leaning forward. It's very common for people with dementia to shift their weight that way, to kind of walk more on the balls of their feet because of changes that are happening in the brain. So you take all of this together, right? And it's really kind of a perfect storm in terms of fall risk. I want to talk now in a little more detail specifically about this change to the visual field that's very common in people with dementia. And again, I want to give credit to occupational therapist Teepa Snow and her and the positive approach to care. The information that they provide teaches us a lot about these changes. So if somebody without dementia were standing at this vista, wherever this is, and looking at this image, right, you're taking in a lot of information. You're seeing a lot all at once, right? If I'm looking specifically at the path that's in the middle of that, of this image here, I'm not looking exactly at the mountains, but I have an awareness that those mountains are also there, right? We have the ability, when we have full access to all of our peripheral vision, we have the ability to take in lots of information at once. People with dementia experience changes to the visual field because of changes in the parietal and occipital lobes of the brain that I was talking about, that makes vision sort of work differently, right, because of that damage. In the early stages of the disease, even people with very early dementia can have what we refer to, we've heard the term tunnel vision before. That's usually more kind of a judgment of how somebody's thinking. But people with dementia can be living with a view of the world that looks a bit like looking into a tunnel, or what we sometimes refer to it as scuba view, right? Do this if your hands are free. Go ahead and do this and look at how different the computer looks to you right now. If you're watching on a computer screen, the room that you're in, right? The environment around you. Right, so layer that. You've got a more limited peripheral view. You can only see so much at a time. And then consider also having these other symptoms that I've been talking about. You have short-term memory loss or maybe disorientation, right? So if I'm sitting here in this room, I've got scuba view, right, at all times, and I'm looking straight ahead, and somebody approaches me from behind, right? Someone comes up to maybe a coworker, I'm in my office, or my husband comes in from the other room, approaches me this way. I'm sitting here with scuba view, right? And I've forgotten that that person was there, right? Because I've got short-term memory loss. Maybe I even have disorientation, right? How startling is it to me when that person suddenly starts talking to me? I forgot that they were there, or I didn't know to begin with that they were there, right? So we easily startle people living with even very early dementia all the time. We throw them off, right? When we talk about fall risk, when we talk about walking, ambulating, navigating steps and stairs, right? We're used to sort of thinking about what those stairs look like to us, right? I can take in all the information of the room around me. I'm looking down at the steps or the stairs, but I also have an awareness of my destination. I know how many steps it is I'm about to climb, right? Hopefully it's well lit. I have a sense of who else is in the room with me. If somebody over my, shoulder over here starts talking to me, I probably knew that they were there because my memory is functioning normally. I hadn't just forgotten within a couple of seconds or minutes that they were there. So if they start to say something while I'm beginning to take my steps and ascend those stairs, that's not going to startle me, distract me, throw me off, right? Make me turn my head and wonder who was that, right? Because I can sort of process all of that at the same time. Again, I'm encouraging you to really marvel with me at the wonders of our brains and all they're doing when they're working properly for us, right? So that's what early stage vision frequently looks like. And then it just gets narrower and narrower as the disease progresses. In the middle stage of the disease, people frequently have what we would refer to as binocular view. So we refer to this as task vision. If I'm sitting here eating a meal, right, I can look down and I can see the plate that's in front of me, but I no longer have any vision or even awareness of everything else, right? I've lost my context for everything else that I was doing. This is very important for us to remember as we communicate with somebody who's living with dementia. We can't just keep sort of talking at them, talking to them, distracting them with other information while they're trying to focus on a task. And that includes walking, right? And getting in and out of cars and all of these other high risk sort of activities. As the disease continues to progress mid-late stage, we're likely to experience monocular view. It's not that people can't see out of both of their eyes, it's that the brain is beginning to have difficulty processing information from both eyes at the same time. So it becomes a bit like looking through a pair of binoculars, but with one of your eyes closed. Right? Now, think about just how different the flooring looks. Think about how different a path that you're walking on, a set of stairs, how different all of these, when we talk about throw rugs and clutter and obstacles around the house, think how different they look when you're walking around with monocular view, right? You're seeing very little of it. In the late stage of the disease, the person is likely to have a very limited field of vision, if not total vision loss. It's not common for people with dementia to totally lose their vision, but the brain is becoming much more, is struggling much more at processing that information. So to that point, what I'd like you to just consider here is, looking at this, if you're in this room and you're about to walk outside, you're about to go through this slider, have a look at the room, right? What do you see there? You can see that, I sort of guess there's a door there and there's also maybe a screen behind it, not totally sure. It kind of looks like there's a difference between the door and the window next to it. So maybe there's a second door I'm gonna have to go through, a screen. I'm also aware that there is some kind of a tool, I don't know, a Swiffer or something on the floor in front of that door. And I think I'm also seeing a pair of shoes, right? This is even hard for me to make out with pretty normal cognition and pretty normal vision because of all that shadow, right? All that difficulty, all of that sort of distraction, I should say. this is what the same scene might look like to somebody who's living with dementia, right? Even very early stage, when you've got that kind of scuba vision, everything around what you're looking at exactly. And of course, if you're headed out this door, you're probably keeping more of an eye toward the handle of that door, as you see in this image. You're not necessarily looking or thinking about the floor. So it's pretty much impossible to tell in this second view that anything is on the floor there to potentially trip you or get in your way. And you probably also can't tell that there's going to be a second door behind that one. If there is in fact a screen there, I don't know if there is, but if there is, you don't know for sure that you're going to encounter that. And so you might also have some difficulty once you do get the door open, if you make it there safely, getting out. So I hope that this helps sort of explain what some of those visual field changes look like. Again, I think it can really help us kind of think more empathetically about what a person with dementia is experiencing day to day. You're probably well familiar with the connection between taking multiple medications and a person's fall risk, right? This is true for everybody, not just people living with dementia. When you're taking sleep aids, some of the cardiac drugs, pain medication, allergy meds, Benadryl, we are hearing a lot about diuretics that dehydrate us on purpose, and alcohol. Right? All of these medications and substances increase fall risk for everybody, but there are some special considerations we have to take into account for people who are living with dementia. First of all, if you are a person living with dementia and you've got any of this sort of sensory impairment, verbal language impairment, memory problems, all of that makes it much harder for someone with dementia to accurately report side effects that they're having. If they are experiencing dizziness, if they are maybe having falls and they need to talk with their doctor about that, it's entirely possible that a person could experience dizziness, falls, and then the next day not remember that they had that experience. This could sort of be happening every day. When I take this medication at 5 p.m., by 7 o'clock, I feel dizzy and I have a fall, right? By 8 o'clock the next morning, I may not know that that's happening. So we do have to consider that just because a person with dementia isn't reporting any problems or difficulty with side effects, that doesn't mean that they're not happening. It can be much harder for people, of course, living with memory loss to be compliant with how they're supposed to be taking medications, timing, right? This one needs to be taken with a glass of water, and then you have to sit upright for an hour, whatever the recommendations might be. That's hard enough for any of us. It's especially hard for somebody living with dementia. And then again, think about the changes to safety awareness that I've already talked about. Insight, right? If I'm not aware that I have a memory problem at all, many people with dementia don't know they have any memory issues. We call that anosognosia, not being aware, not having insight into one's own disability. This certainly impacts a person's safety awareness. My judgment, do I really need to be, I don't even remember why I was taking this drug in the first place. I don't think I need to take this. Or I can't remember if I took this pill today, yesterday, I better take 2 today, right? These are questions, judgments. This requires a level of insight and safety awareness, managing medications that many people with dementia are not able to manage independently. So in keeping a person with dementia safe and lowering their risk of falling, one of the most important things we can do is to talk about their medications. So ways to reduce the risk of falls for people who are living with dementia at home and in the community. First, as I kind of indicated before, we have to think about dementia as a progressive condition. Unfortunately, as I said, we don't have effective forms of treatment, ways to halt, stop, or even or reverse, or even just sort of halt the progressive loss of function that happens with Alzheimer's disease and most progressive forms of dementia over time. We have to just sort of work with that reality. Most of us as caregivers, when we've cared for another person, if it was a child, right, we supported them as they developed, as they gained function, as they learned new skills, or we helped somebody through rehab, right, getting better after they, broke a limb, or had a fracture, recovering from a flu or an illness, somebody who went through cancer treatment and then, sort of got stronger over time. Rehabilitation is our normal sort of mindset when we're supporting somebody as a caregiver or as a care partner. We have to think differently about dementia, because at the moment we don't have a way to rehabilitate people. What we do instead is we habilitate, right? We meet people where they are right now. We assess, what is this person's level of function? What can they understand? What can they tolerate right now? And we work with that. We don't push in the way that we do with somebody who we are rehabbing. It's a very different way of thinking, and it's a really important shift that we have to make as caregivers. As I talked about before, the learning of new skills is impaired. And over time, it will become impossible for most people. So we just have to be reasonable about what it is that we're asking a person with dementia to do. Most people, when asked, will say, I want to be on my own. I want to be independent for as long as possible. Of course, this is a totally reasonable, worthy goal, but it's just not realistic for most people living with a progressive form of dementia. What we need to focus on instead is helping people with dementia be autonomous, right? Be in control of their movements, be as in control of their choices as they can be day to day, but true independence, letting somebody just live alone, make their own decisions totally independently. Unfortunately, over time, this is just not a realistic goal. We have to be flexible in what we expect of them, but also of ourselves. Having said that, the flip side of that issue is that risk is a part of life. Right? Those of us that went to social work school, many of us were trained in a concept that's called the dignity of risk. Right? Life is risky. We're all, we get in cars, we take walks, we, go, you not even just walking out your door in your own home, right? Risk is a part of life, and we cannot put people with dementia in bubbles, right? And totally insulate them and protect them from all risk. But what we can do is think about ways to reduce the likelihood of those injuries, or to minimize the harm if they are going to experience falls. So some specific fall prevention strategies for if you're caring for somebody who's living with dementia, or if you yourself are living with memory loss or early dementia, some things to be thinking about. Stay as active as possible, right? Although the brain changes in dementia are sort of unfortunately fairly inevitable and progressive, the rest of the body is involved in all of this too. So if we can keep the heart strong, we can keep the muscles strong, we can keep the core and the trunk strong, right? Maintaining strength, staying as flexible as possible, continuing to do exercises and work on balance. There's no reason to stop doing those things if they do them now, or to start doing them if they're not already doing them now. Because the person, yes, there's going to be vision changes. There's going to be changes to that center of gravity and that shift toward the balls of the feet, for example, that I was talking about before. But there's no reason that we can't keep those core muscles, the back muscles, the quadriceps, the glutes, keep them as strong as possible to minimize, to sort of help kind of counteract some of the brain changes that are happening. So I know through Fall Prevention Week, there's been a lot of great sessions on staying strong, working on your balance. If you haven't been attending those live, I know the recordings are going to be available. Watch them. They're applicable to everybody, right? People living with dementia can and should continue to walk and stay as active as they possibly can. Think about overall health the way anybody else would, right? Eating enough during the day, eating a nutritious food, most importantly, probably staying well hydrated. As we age, our thirst sensors change naturally. We become less aware of thirst and have to more consciously think about, gosh, it's been a long time since I had a drink of water. Has it been a long time since you had a drink of water? It has for me, so I'm going to take a quick sip. There's my reminder to myself. Staying hydrated is even harder when you're living with dementia because you probably have that disorientation to time. You're not aware of when the last glass of water was that you drank, how long ago that was, but also because of those changes to sensory processing, is that sensation that I'm feeling actual thirst, right? My brain has to tell me, Amy, you're feeling thirsty. It's time to take a drink of water, right? So that's impaired naturally, normally as we age, especially so when people have these brain changes associated with dementia. So we as care partners have to be sort of in front of that. We have to be proactive, remembering what I was talking about before, difficulty with initiating, right? Even if I'm sitting here, a person living with dementia, and I'm sitting here and I am aware that I do feel thirsty. It's probably been a while since I had some water. I ought to get up and go get some. Remember, I may have that sort of apathy, that difficulty with getting started. That's just gonna, I'll do it later. Right? And then the whole day can go by, I can become totally dehydrated. At a certain point, something startles me, I need to go to the bathroom, whatever it might be, I get up, right? My blood pressure is very screwy because I'm totally dehydrated or I haven't eaten all day, right? This again, it's this sort of perfect storm. So staying on top of overall health, right? Managing blood pressure, eating well, hydration, it's important for everybody. Dementia is no reason not to pay good attention to these things. Sensory processing, having hearing checked regularly, having vision checked regularly, hearing aids, glasses, these things help people with dementia. They're imperfect. I mean, yes, because you have to remember to change batteries and remember where the darn hearing aids are, get them in and out. Eyeglasses sometimes can be difficult for people with dementia to manage, but certainly if we want to lower the risk of them falling, we want them to be able to hear and to see as clearly as possible. So talk with your doctor about any and all of these things, right? Lean on your pharmacist. Pharmacists are really underutilized resources for us as caregivers to people living with dementia. Talk with them about the medications that this person is taking. Do they need to be taking all of these? Are they being dosed at the right time, right? If you're concerned about falls, talk about that and ask about ways that maybe the scheduling or the dosing or administration could be changed to lower the person's risk of falling. And then of course, lots of things that we can do around the house to improve safety. So we'll go into each of these. Medications, as much as possible, reduce the likelihood of polypharmacy. Try to get all those medications from the same place so that the red flag will sort of trigger for you, for the doctor, for the pharmacist, or if nothing else, there's a computer system that will trigger kind of a red flag warning. These two things taken together don't look safe. Right. So if all of that information is in one place, then the likelihood of somebody catching a potential negative interaction that could cause a fall is higher. Again, talk with the doctor, talk with the pharmacist. Using pill organizing systems, making sure that medications are being taken as directed, or just stepping in and taking control, taking over the management of another person's medication may be what's required in order to keep them safe. I know that this is tricky terrain. This is difficult for people to talk about and think about, but medication is a really important area of overall safety for people living with dementia for the reasons that I've described, but especially when it comes to fall risk. So it might just be better to keep the medication stored somewhere else that person doesn't go. If the medications are out of sight, they may remain out of mind. So common problems that we see in the environment, and all of this will look familiar if you've been attending other fall prevention programs over time. None of this is specific to a person that's living with dementia, right? Not having good lighting, having clutter, things on the floor, like that image that I showed you before, seating or beds or toilets that are too low, that require too much strength to get up and down, stairs and steps, thresholds that are not even, slippery floors, either because the surface is itself slick or the person is in stockinged feet, or because there's spills, right? Kitchens and bathrooms are often slippery, not because of the surface of the floor, but because there's water and things that have spilled, not wearing proper footwear, out walking on uneven sidewalks. Most neighborhoods in San Diego County, our sidewalks are in pretty bad shape if we even have them. So a big trip and fall hazard, and of course pets. I know there was a session earlier this week on walking dogs safely, which I was so happy to see, because pets are a huge source of falls for all of us, not just people that are living with dementia. So again, keep in mind, when you think about all those problems, think about those symptoms that I walked you through, the changes to the visual field, how the environment looks, feels different to a person who's living with dementia, how short-term memory loss, how that rapid forgetting might affect your ability to manage, to kind of navigate your environment safely. Think about all of that together when you think about potential solutions to the person's environment. It takes much more than just sort of tacking down the throw rugs, a very important strategy, but it takes much more than that to keep a person with dementia safe. So lighting, it's obvious. There's just really no way to understate the importance of adequate lighting for reducing fall risk. The most important strategy for all of us, but especially people that are living with dementia. Again, go back to that scuba vision that I was talking about before, and think about the fact that, you know, lighting needs to come not just from above, right? Because lighting that's coming very strong from overhead, what does it create on the ground and around us? It creates shadow. Shadow can be confusing and cause a person to kind of look down when they need to be, you know, looking up, grabbing a balance bar, a handrail, for example. So what we want is lighting that's coming from multiple directions, right? Using table lamps as well as overhead lighting, using night lights and you know, tap lights, or things that kind of illuminate from the floor up whenever possible. Lots and lots of lighting is really important in the environment for a person who's living with dementia. Think about where this person tends to go. What are their normal patterns of movement, and focus on those areas first. It can be really overwhelming to sort of look through the whole house and think about all of the risks and everything we need to do. Think about the spaces that they use most and start there, right? Have good lighting, have handrails everywhere, but certainly, you know, focus on the areas of the home or around the home, the garage, the paths, the sidewalks that they walk, whatever. Think about those first. Adequate space around the house. Remember, we're not just considering the movement of the person living with dementia, but ourselves as care partners too. Wherever we're removing obstacles, removing trip hazards, clutter, we need to do that for ourselves too, right? We want them to have comfortable seating, you know, with arms so they can, you know, use that to get up and down from chairs. We need that too as care partners. We need access to that person to be there to provide that supportive hand if they need it. So consider the space requirements that you have too. Elevating those chairs, beds, toilets so that there's less sort of squatting and less muscle strength required. Installing those handrails and balance bars everywhere that the person is regularly, right? There's lots of great resources here in San Diego County for getting an evaluation of where you should put those bars. And then lots of great resources here locally for getting those purchased and installed or donated if needed, and installed by volunteers if that's needed. Consider the floor, right? Falls and trips and slips and spills are still going to happen. So consider if it's possible to have softer flooring, right? Soft laminate rather than tile if carpeting is not feasible. Or at the very least, right, putting down non-skid surfaces in those areas that are more slippery, keeping spills cleaned up. That, you know, goes without saying, but I'll say it anyway. Wearing sturdy shoes around the house. This doesn't work for everyone because we got to think about, you know, habits and routines and what a person with dementia is used to. But if you can, try to have them in some house shoes, right? Flat, firm, or slippers, right? Of course, if they don't wear shoes in the house. Something with a moderate sole, not a super thick sole. Please avoid those flip-flops if at all possible around the house for folks that are living with dementia. repair damaged surfaces. There might be, you know, thresholds. Certainly in my home, there are some thresholds that are just sort of bumpy and problematic, but I'm so used to them, I'm not even aware of them anymore, right? So I really encourage you to walk through the space with a fresh set of eyes, find those surfaces that are damaged, repair, make requests of your city for the repair of damaged sidewalk, let people know. Pet care, cats and dogs, right? They really get underfoot. It might just be helpful to have somebody else kind of in charge of dog walking or walking along with the person with dementia to make sure that the dog sort of stays out of their path. Pet care can take on lots of different shapes, and it means something different to everyone, but do consider whether or not having cats and dogs around the house is manageable for the person. And then, of course, this is probably the hardest of all of these realities, but we just have to think realistically, be flexible, consider sort of the long haul here. A person living with dementia, these symptoms are going to progress over time. We have to put support in place, provide them with companionship and supervision over time. This is a topic we talk about a lot at Alzheimer's San Diego. We have lots of classes devoted to the topic of communicating with people that are living with dementia. So if you want to learn more, I'll refer you on to our education program where you can find lots of free webinars and recorded lectures where you can learn more about this. But in brief, how we talk to a person with dementia affects their risk of falling. As I was talking about before, think about, you know, how focused their attention needs to be on the task that they're working on the path that they're walking on. For example, when you consider those visual field changes, the memory changes, the cognitive changes, the difficulty with processing verbal language, knowing what words mean, knowing what signs mean when you read them, and knowing what words mean when you hear them. All of that requires us to communicate with people living with dementia differently. So keep those language and comprehension changes in mind as you're talking. Talk less, right? Don't talk like I'm talking right now. By all means, right? Use calm, slow, clear speech so that the person really has time to absorb. Remember the importance of those visual cues, right? If you're asking somebody to tie their shoe because you see, you know, it looks like maybe the lace is getting a little bit loose, right? Just saying to them, "Oh, Mom, I think your shoe's becoming. I think your shoe's come untied. Tie your shoe." That could be very difficult for a person with dementia to understand. But if you lean down, touch her shoe, touch your own shoe, right? Make the visual movements of tying your shoe, right? Providing those visual cues can be really helpful to helping the person sort of connect what it is that you're saying. Avoid, this is probably the hardest especially for family caregivers to do, avoid correcting people, arguing with them, confronting them. You know, telling a person with dementia no is like the surest way to shut down the communication, cause tension. And it really, it's kind of banging your head against a wall, right? You're sort of arguing about whether or not a certain color is blue or green, right? You can argue all day long, nobody's gonna win that argument. So as best you can, take those deep breaths, right? Step back, avoid getting into those arguments and confrontations if at all possible. And again, keep in mind those changes to the visual field that I talked about. Keep in mind a person's need to feel autonomous. Keep in mind a person's lack of insight. If they don't know that they need help with things, and suddenly you just show up right next to them and you're there to offer a hand or an arm to help them getting up and down out of a chair or getting up and, you know, navigating some steps or a path. They may not understand why you're there, right? They may not have remembered you were there. It may startle them, or they may just be like, get away, I'm fine, I don't need your help, right? So be mindful of how people feel, how they're interpreting their own personal space and how they feel about your help, right? Doesn't mean you're not going to help them, but you may have to approach how you help them a little bit differently. So this is what that positive physical approach, the positive approach to care is all about. In the interest of time, and also that I don't have anybody to demonstrate this with me, I just wanted to give you some basic information. You can learn much more about this at Teepa Snow's website if you're interested to learn more about it. But making that positive physical approach is all about recognizing those brain changes, the visual field, not assuming that just because I'm in this person's space, they know I'm there and they know who I am, right? So you always announce yourself, you say, hey, it's Amy, right? Giving a little wave or something to get them kind of looking toward your face, making eye contact, coming in, offering a handshake, right? When it's safe for us to do that, given your particular relationship with the person, right? Standing in a supportive way so that they can see you, they know that you're there, and again, you're not just walking right into their personal space. Those are the foundations of this positive approach to care. If we're helping a person with dementia, with stability, with walking, preventing falls, going up and down steps, we've got to get into a position that is supportive, where we can be helpful, but we have to do that in a way that they welcome us, right? It doesn't feel like a violation of their personal space. That's what this is all about. Right? The hand under hand technique is a wonderful device that we can use for assisting somebody with mobility, knowing what we know about the anatomy of the human hand, right? How much we respond to gentle pressure, the way that our skill fingers versus our strength fingers work. We can use all of this knowledge to get into a position that we call hand under hand with a person who's living with dementia, so that we can sort of help them navigate the use of a walker, a cane. We can help them get their hand on that balance bar, for example, to hang on when they're in the bath or the shower, so that they feel more secure. We can kind of move their hands around and help them in a way that, again, they still have that sense of autonomy. Their hand is on top, our hand is below. We're sort of steering from underneath, but their brain really feels like they're in charge of that movement. It's a very helpful technique if you're providing hands-on day-to-day care with a person who's living with dementia. So I'll just encourage you to reach out to us. We teach and we train in these methods, or reach out to Teepa Snow's team directly if you're interested in learning more about these techniques. So give yourself lots of time. Remember that visual cueing. When we're interacting, when we're supporting somebody who's living with dementia, we do often want to talk because we're used to that. We're social, right? But giving them, lots of barking out instructions and orders, as I mentioned before, is often not helpful to them. So engage in sort of low-level social chit-chat, sing songs together, right? If you can get the person sort of walking to a rhythm, often they're no longer really trying to think through all these sequencing. We can let their procedural memory, their muscle memory sort of kick in, right? By setting a walk, setting movement to a rhythm that they recognize. And if music's not available overhead, hum it, right? You can hum along, right? Being as simple, as clear, as direct as we can with verbal prompting. Give lots of positive reinforcement. You're doing a great job. Saying yes, remembering that visual cues are helpful. So do lots of nodding, lots of smiling, lots of ways we can give people praise, reassurance, and comfort without saying anything at all. Right? But do lots of that. Fear and discomfort is a big obstacle for a lot of people, but especially for people living with dementia. And again, in the spirit of helping people be autonomous, focus on doing things with a person with dementia, not doing things to them. Right? Here, you need to grab this bar, you need to do this or that. We tend to just sort of take the person's hand and put their hand right on that bar. We're doing that for them. Instead, what we want to do, get into that supportive position, right? Bring their hand to it. Do that task together with them. When we're walking together. We're not just helping the person because they can't do it on their own. We're taking a walk together. We're engaging in this activity with the person. We're not doing things to them or stepping in and doing things for them, right? That never feels good. Even if you are ultimately really doing something for a person who's living with dementia, you don't want to make it feel that way to them, right? You want this to feel like an activity that you're doing together. So finally, I'll just cover a couple of resources for more information and help if you need it. This is a lot, right? I've covered a lot of information, and I'm really asking a lot of somebody who's caring for someone with dementia. And I recognize that, right? We aren't asking you to do this alone. So think about your own health, your own well-being, right? I mean, if you're going to be helping somebody with ambulation, if you're going to be helping around the shower, bathing, cooking, getting dressed, all of these places around the house that a person with dementia might be more likely to fall, you need to be in pretty good health and pretty good shape yourself. Right? So do you have time for exercise? Are you working on your own balance? Are you paying attention to your own health or nutrition and hydration during the day, right? You need to be prepared for the physical demands of caregiving. If meeting these physical demands is not possible for you, then you need respite. You need somebody to come in and provide some assistance. So I think just having that kind of reality check is really important. So keep yourself strong, keep yourself healthy, get enough sleep, right? Not being able to sort of function at your best because you're not sleeping well at night, that undermines all of these great tips and strategies I've shared with you. It all flies out the window if you're too tired, right, to respond, to think about how you're verbally communicating and provide those visual cues, and stand in a supportive way and consider their vision needs and not startle them, right? You got to be pretty mentally on your game in order to think about all of that. So attend to your physical needs and your emotional needs. Keep learning, right? Learn those techniques for ambulation, safe transferring from a lying to seated or a seated to standing position, for helping somebody once they have fallen. Fall recovery is very important. These are all techniques that we've got resources we can teach you, or we can share other community resources with you. You can also find a lot through SanDiegoFallPrevention.org too. So get respite and have a safety net, or you cannot be doing this 24/7. It's just not feasible for any person. So this is us as an organization. Visually, all of the supports that we provide at Alzheimer's San Diego. Please don't hesitate to reach out if we can be of any assistance. And that's it.
Perfect. All right. Thank you so much, Amy. I know that we're a little bit short on time, but we can maybe take one or two questions if Amy's available. Can we do that? Maybe one or two questions?
Oh yeah, sure. Sorry.
Okay, perfect. I know we're past 10, so I just want to make sure.
Yeah, no, that's fine.
Okay, so let's see. If you want to use the chat, you can. We'll just give it a minute or so.
Yes, and just to answer that question that I see there, this session is being recorded, and Carolyn, where can they find that later?
Yeah, so we are going to be posting all of the workshops on our website. So I'll go ahead and put in the chat that website. It's www.sandiegofallprevention.org. We will be probably editing some of the videos, so it might be up by the end of next week, but hoping to get that to everyone soon. So I see one question here. Does depression and anxiety increase the dementia diagnosis?
Oh, let's see. So people that have, depression is actually one of the lesser risk factors for developing some types of dementia. Yes, people with clinical depression do develop dementia in slightly higher numbers than people without depression. So the relationship is not causal. Depression and anxiety do not cause dementia, but many people with dementia also have sort of depressive or anxious symptoms as a part of the disease process. So it's kind of a complicated relationship. But yes, these things do coexist. It's very important that we recognize when a person living with dementia also has an untreated depression or anxiety. They can respond to medication, they can respond to therapy, they can respond to exercise and other things that help alleviate the depression and anxiety symptoms. We don't have to just write it off to, well, this person has dementia, so they're just going to be depressed or anxious, right? No, these are treatable conditions, even in people with dementia. great question.
All right, just seeing lots of positive comments, positive feedback.
Great. Thanks, everyone.
Yeah, thank you so much, Amy. We really appreciate it. If anyone has any additional questions, you can go ahead and send us an email and we can push it through to Amy. But thank you so much again. And I think we'll go ahead and close. But have a great rest of your day, everybody. And hopefully we'll see you for the next 3 sessions for today. Thank you so much.
Great. Thank you very much. Thanks for coming, everyone.